ready to start in that case. Welcome everyone to the December Health Scrutiny meeting, the last one of quite an interesting year, one way or another. Okay, just a reminder to everyone, this meeting is being broadcast live now on YouTube apparently, and is also being recorded. Under urgent business, I'm going to invite Councillor Wills to speak. Today is World AIDS Day. Normally, Councillor Wills would be leading on us marking this at full council when we were all together, but that's not a thing at the moment. So I'll just hand over to Councillor Wills now.
Thank you very much, Chair. Thank you for the opportunity to speak at the start of this meeting about World AIDS Day. This is an event that's been marked on the 1st of December every year since 1988. And normally here in Manchester, we would have a candlelit vigil this evening in Sackville Gardens. Clearly, given the current circumstances, that's not possible this year. However, the partnership Passionate About Sexual Health, or PASH for short, have organised an online vigil, which is being supported by Manchester City Council, and that is going to be streaming at 7 p.m. this evening on the George House Trust website. I did send an email to members on Saturday evening about this, but if need be, then I can, and if the chair's happy, I can ask Lee to circulate the link again after this meeting. There's also the opportunity to make a donation to PASH. You can just text the word ribbon, and so on, to 70085. So we still have this opportunity to remember whose lives we lost living with HIV today, and commit to not only end HIV, but also aim to end all new transmissions of HIV by 2030. The theme this year for World AIDS Day is global solidarity, shared responsibility. So it's not only about coming together, but also recognising the part that everyone has to play in ending the HIV/AIDS pandemic. I think it's important to note as well that this year with coronavirus and lockdown, it's been especially tough for people who have HIV globally. It's a struggle for many of those people anyway, in terms of accessing medication, in terms of fighting against the prejudice that they encounter and the stigma. Many surveys have shown that a lot of people living with HIV have lost their jobs, and they've also struggled even more to access treatment during this time. So continued access to support and services becomes even more vital. Manchester, just to remind everyone, is now one of the fast-track cities, global alliance of cities that have made a commitment to meet the terms of the Paris Declaration and the so-called 90-90-90 target, so that by 2030, in Manchester and these other cities, 90% of people living with HIV know their status. 90% of those who know they are HIV positive are on antiretroviral therapy, and 90% of those who are on antiretroviral therapy have an undetectable viral load. In other words, they cannot pass on HIV. So, you know, George House Trust ran a campaign with the slogan "U equals U," which is undetectable means untransmittable. It's also worth noting, finally, that just this morning, the cross-party HIV Commission launched their report looking at how these goals can be achieved in England. There is an executive summary with all the recommendations available online, and again, if the chair's happy for me to do so, I can send a link to this to Lee for circulation. But kind of among the key asks are that England should take the necessary steps to be the first country to end new HIV transmissions by 2030, with an 80% reduction in transmissions by 2025. Jointly, the Department of Health and Social Care and the Cabinet Office should report to Parliament on an annual basis the progress towards these three goals. That national government must drive and be accountable for reaching this goal through publishing a comprehensive national HIV action plan in 2021. and that HIV testing must become routine, that it should be opt-out rather than opt-in with HIV testing across the health service. And obviously, it's really important to ensure that any testing programme like this is acceptable to all communities and that nobody is left out. So those were the main points that I wanted to make, and yeah, just first and foremost, encourage people to tune into the vigil this evening and to donate to PASH if they can. I think that's all I have to say. I don't know if Councillor Craig has anything she wants to add.
Thanks, Councillor Wills.
I think you covered it wonderfully, Councillor Wills. I think all I would do would be to say a massive thank you to all of the. I think we're blessed in the city with some really excellent clinicians that have been leading the fight against HIV and AIDS, and also voluntary and community sector organisations and groups in the city. So I think that's one of the many reasons why we're happy to be supporting and facilitating the vigil tonight.
Great. Thanks to both of you for that. Moving on, I'm not notified of any appeals. A reminder to members to declare any interest they may have, either now or if they come up during any discussions that we have. Item 4, minutes of the meeting on the 3rd of November. Can we agree those as an accurate record?
Agreed.
Yes.
Thanks, everyone. Nothing urgent.
Agreed.
Nothing urgent anyone wants to bring up on that? Okay, we have a slight change to the advertised running order because of the availability of some of our speakers, some of whom are obviously very tied up with other matters at the moment. So we are going now straight into item 7, which is mental health service and COVID-19. As ever, if we work on the basis that members have read their papers, if there's key points that anyone wants to bring out on the report, over to the speakers.
Hi, I'll be speaking today. I'm Deborah Partington, Director of Operations at Greater Manchester Mental Health. Unfortunately, I'm having trouble with my video, so you may be able to see me, but not, hear me, but not see me. So apologies for that. I'm here with my colleague, Associate Director of Operations, Adam Young. Both of us have been to this committee before. So as you say, Councillor Farrell, we'll take it as read that people have seen the document, but if I just pick out some of the highlights of that document, and then you can ask any questions you want to, obviously. So earlier on in the pandemic, we did come and give a brief update on our preparedness for the COVID pandemic. Obviously been working since then through the stages that the NHS have given guidance on. So the first stage being the emergency response, which we think we have given some information to this committee before. The release from lockdown, that May to July period, when things started to become a little bit more settled, but of course for mental health when we started to see some of the impacts occurring. Living with COVID from August this year right through the winter, and that's what we're working mainly on today, and building back better, which is phase 4 of the NHS plan, and we're still awaiting guidance on that, but we know it's arriving. So just to say that as all organisations within the NHS, we went to a goal command structure during COVID, and we began that in March this year. That's meant that we've reviewed our situation daily, been in touch with national bodies, done the same as every NHS organisation. I'm sure you've heard quite a lot about some of that, but certainly been considering the risks and the operational response to that very quickly. In the document that you've got on page 4, there is a governance diagram that details some of the ways in which we've worked. We work directly daily with 3 Manchester divisions, that's North Manchester, Central Manchester and South Manchester, who specifically consider the locations within Manchester, but also within our organisation, we have specific areas that look particularly at IAPT, those psychological therapies, rehab, and of course the specialist services that Manchester residents are within, which includes some of our children's and secure services, but also the prisons. And we know that Manchester has its own prison, and we do provide the services there too. So after the first phase of COVID, we realised that much needed to take place in relation to recovery. We have a huge programme of recovery work streams. They're detailed on page 5. I think probably some of the things you're most interested in will be the orange box in the middle, which details all the service offers, and there's task and finish groups in relation to those, but particularly those that relate to managing our demand, the crisis response to services, so those at A&E, helplines, dealing with people in the greatest need, and then of course the community response that prevents people from escalating up that system. So lots of information in that diagram. And there's also information in the paper on page 6 about our physical health response, because of course whilst we're a mental health service, we still need to respond to the physical health needs of the population we work with, and that includes needing to be adhering to IPC requirements. So all our one-to-one visits in the community, all of our inpatient services are abiding by the rules you'd expect, with full PPE and social distancing arrangements. So those things now take place with those measures in place. But some of the achievements over the last few months, we set up very quickly indeed a 24/7 crisis helpline. It's one of the busiest in the countries, and we're taking over 600 calls a week into that helpline, and either working with people who we know on those lines or diverting them directly into service. We've set up urgent care centres in each of the A&Es in Manchester, and they're still in process of developing. I know you've got a presentation on some of this, and we've absolutely been included in that work stream and the response for people with mental health needs who arrive at A&E. We're working very closely with NHS England. In fact, that's where I've got to go at 3 o'clock, is to present to NHS England on ensuring that money's come to the city for crisis moving forward, and we have achieved some funds for this winter. And of course, our IAPT offer has completely changed over COVID. The majority of that is now taking place virtually, and there's some information in the document around how we've assured ourselves that that's appropriate, with some face-to-face now occurring. Community models, we see over 3,000 people in secondary care CMHTs in Manchester, and we've been developing systems that make sure that everybody's seen and within good time scales, and we monitor those 3 times a week to make sure that everybody's been seen. We have a homeless team here in Manchester, and they work very closely, of course, with the Everyone In campaign and the work that's now developing. In our later life teams, we've had people working directly with the care home sector to ensure that people who are looked after in those services have got our support. And particularly in Manchester, we've had the student mental health service that only began in September last year, and has also had to respond to the increased needs of students during the last few months, and we've actually had to redeploy people into that service to be able to cope with some of the demands that there have been. So that just gives you a bit of a flavour of some of the task and finish groups. If you look at page 10, we're very proud to say that we're benchmarked every month against every NHS mental health service in the country, and we've come top of the pack at making sure we have contact with patients in the community. So very proud of the fact that we are in contact with people regularly, and we do believe that regular contact and assessment is preventing people escalating up those levels, up the different services that we want to prevent. Lots of work in there about how we've developed our workforce particularly. I wasn't going to go into great detail about how we've done that, but we certainly have supported the workforce to work from home if they can. But we've on the whole, with clinical services, have a blended model. That means that some services workers are within the bases and sometimes working at home, working on teams, seeing people both virtually and face to face. But I think probably significantly for this meeting, we are predicting and are starting to see a 10% demand at least in every service now. So it's what we predicted when we started to do some of the modelling. But if you go to page 14 in the paper, you'll note that this time last year, between March and May, we had about approximately 350. We have 350 fewer people being referred to as between March and May, and now we're seeing this to be additional 500 to what we would normally see. So in community teams particularly, we're seeing anything from between 10 to 30% more people being referred into service. That's demonstrated in one of the community slides on page 15 that just relates to community mental health teams. There are other community teams as well, but we have maintained reduced waiting times at this time. So that is a combination of digital and other things that are occurring. I won't go through all the crisis response, I think that speaks for itself, but inpatient admissions have also increased. We're seeing, and we predicted a 10% surge, and on page 17, if you look at that diagram, you'll see that bed nights, which is what we usually try and count because it gives a better understanding of the picture.
Deborah,
yes?
I think we have different page numbering on the papers that we've had to those that you're...
Oh dear, right.
So if you're doing page references, could you say like 4.6 or 4.4 or whatever? Because I think we might be having some trouble up with that. I think that's just got lost in translation somewhere.
Oh, sorry about that. So I'm actually referring to chart 5, which is under section 4.6.
Oh, got you. Yep, thanks.
Yeah, that is it. Yeah, sorry about that, everyone. So the chart at 5 demonstrates bed nights that are used. And if you see from January last year, we're average bed nights for Manchester were roughly about 220, as you can see. And what you now see is something that's risen well above what our average would be, and that's been fairly consistent since about July time when we started to see some of the surge in mental health need. It dropped, as everything did, during that first phase of COVID. So we are now seeing and trying to make arrangements for people that keep them in Greater Manchester and stop that reliance on out-of-area placements, and that has meant some additional private sector placements in GM being secured. We have also, I think I've already mentioned about the student mental health, but also there are plans particularly to get people out of hospital over the winter. That's certainly a group of people who need to be out of hospital in secure accommodation. And we have been supported this winter with some funds to start implementing some of that work speedily, because we have got a long-standing issue in Manchester of people who are detoxed, which are people who are waiting for discharge and ready to go. Also in the paper we just put in the how we link into the system, so we're very much involved in a system approach. We're meeting 3 times weekly, I should say, at the moment with the Manchester and Trafford Community Cell. That includes the Acute Trust, the CCG and the PCNs and the local care organisation, all meeting regularly to support each other with the demands that there are. And we've also just agreed some plans with the CCGs to bolster some of our community teams to be able to cope with some of that demand. So sorry if that was a little bit higgledy-piggledy, because your page numbers were not correct, but hopefully if there are any questions, myself and Adam can answer them.
Thanks. Do any of your colleagues want to come in on anything, or are we happy just to go into questions?
Adam, is there anything further you wanted to add before we go to questions?
No, I think the point that you added at the end in terms of the demand, the increased demand that we modelled and expected has been coming, but we have been fortunate around support from the CCG with some additional resource until the end of March at the moment for us to bolster and sustain our community mental health response and continue the trajectory of improvement that we have seen and timeliness of our response through the pandemic to the community and our service users.
Thanks. Okay, I've got a couple of indications already from members. If you could use the chat, that's quite helpful as well. Otherwise, try waving. A couple have been notified before the meeting. Councillor Doswell first. For colleagues' information, we're joined by 2 new committee members today. I forgot to welcome them at the start of the meeting, so it's Councillor Doswell and Councillor Hitchin, our new members. Councillor Doswell.
Thanks, Chair. Hi, thank you for that presentation, Deborah. I just wanted to ask a little bit more about 4.7 on student mental health. I represent Fallowfield, which I'm sure most of you will know there's a lot of students in my ward, and we've dealt with a lot of kind of queries of students who just don't feel they have access to any mental health support. So I wondered whether what's been outlined in this report has any links to the universities, and whether it was set up specifically, it doesn't look like it, but just some clarity on whether it was set up specifically to deal with the mental health needs arising from COVID and isolation, or whether it was sort of slightly wider than that, and yeah, whether there is any kind of link up with the universities, and in terms of communication to students as well, how this service is communicated, because there's a lot of people that feel like there's a real barriers to accessing that support. So yeah, if you could outline a bit more about that, that would be really great. Thank you.
Okay, thank you. The Student Mental Health Service was something that was set up a year last September, so it wasn't set up in relation specifically to COVID, but it is something that's quite unusual because it is something that's funded by GM and GM Transformation, the universities themselves, so Manchester Met, Manchester Uni, Salford Uni and Bolton, and the Royal College of Music. So it's those 5 universities that we work with, and the idea is that we work directly with the local team. So the universities themselves already had local counsellors or support staff that's a first line, if you like, of support for students, and our referrals all come through that team. That's how we work currently, and I do think there have been some issues with perhaps some of those teams not being available. They're small teams, I think, and that's been possibly an issue, but we have seen a huge increase in the numbers that are referred to us at the same time. So we, as I just mentioned, we've actually redeployed some additional workers into those teams to be able to cope with some of the demand that's coming through. But if people still think that they don't know where to get that support, I'm sure we can, get some more information out if you think there are places where that would be better communicated. Adam, did you want to add anything more on that?
No, I think you've summarised it well, Councillor Doswell. In terms of the referrals in with the local teams within the university services, I think there's been challenges around access with them. But within the GM University service that we manage and support, we have put in additional resource to try and meet that gap. And we have seen a significant increase over what capacity we have within our service. Hence, we've needed to expand and support that service further. But I'm more than willing to look at any examples outside of this meeting further in different ways we could support if needed.
Fiona?
Yeah, so I'm Fiona Meadowcroft. I'm here from the CCG to support Adam and Deborah, and it was just to highlight that, yeah, that particular service wasn't set up in response to COVID, but what it has done and what COVID has done is highlighted about the routes into that service could possibly be improved, because we did set up a group with all the local GPs, all the university GPs, and that was some feedback we were getting from them. So we've put some of those GPs in touch with the commissioners of this Greater Manchester service, which is the Health and Social Care Partnership. So we're kind of learning from what's occurred.
That's really useful, thank you.
Yeah, no, I've forgotten how to unmute. Just before we move on, do we have any further questions, points on specifically student mental health? Because there was things that came up in the pre-meeting, or were those answers okay?
Chair, I had a meeting on that, but that, you know, it's been answered. But I do have a question on this strategy itself. So
okay, I'll add you to the list in that case.
Okay, thank you.
Okay, next up, Councillor Curley.
Thanks, Chair. Just a few comments really on the students. I'm really pleased that this programme seems to be working well, and I understand the comments of the councils, local councillors and Falfield, so I understand that. But it's good. It just seems that there's access there, which is always encouraging. Just a couple of other points, really, Chair, that I wanted to make. And under the crisis line on page number 27, at the very top there, and this is really good to have this established 24/7. It's really good. And it's all ages as well. I was just wondering to what effect, if any, and is there a mechanism for engaging CAMS in this setup? Because I think that would be really helpful if it could be done. And on down near the bottom of the page on IAPS, Chair, there's a mention made there of you know, the secondary referrals and waiting, and there was 1,000. There's a figure there of 1,000 clients. What sort of percentage is that of the total? And then I think really, Chair, one other point under homelessness. Again, it looks like there's a good case put there, and the 24 session seems to have captured the imagination and involved the 450 people. So that's all my questions. Thanks, Chair.
In terms of the crisis line, Councillor Curley, we established that as a 24/7 service, like you say. It is all age service, and what we've been really trying to do, well, we've successfully delivered within that service, is it not just be a real health focus. So we've engaged a directory of services with all the VCSE sectors across our organisation within Manchester, Salford, Bolton and Trafford. And we are signposting people where appropriate to local services and local voluntary sector services through that mechanism, and also through to local council services where appropriate. As you mentioned, it is all age services, and we work with partners across in Pennine, who also manage CAM services, and also with MFT for Manchester, run our CAM services, and we're closely linked and divert and direct people to those services as appropriate. We also have access to within the 24/7 helpline. It isn't just necessarily for mental health, so it has access to 24/7 substance misuse services if needed. So it isn't just a broad mental health line in terms of that, and it does access into third sector services. In terms of the second point, I'm really going to have to apologise. I missed what the question was with that, Councillor Curley.
If I can, Chair, it's just really on the third bullet point on page 27 under IAPT. There's mention made there of the service have been reduced for secondary waitings throughout Manchester and by over 1,000 clients. And I was just wondering what sort of percentage that represents. Thanks.
Okay, apologies, I wouldn't know as a percentage, but it's something I could look at outside of this meeting and get back to you. But it's basically for people that have had a first line assessment and getting follow-up appointment that people have been waiting. We've managed to clear that backlog during the pandemic, but I will get the percentage and come back to you on that. Apologies.
Next I have Councillor Holt.
Thank you, Chair, and thank you to Adam and Deborah for a really comprehensive report. I just wondered anything else you can add in terms of the transition from childhood to adulthood. I know that it's always a tricky point, and both in terms of the added impact on people's mental health in those kind of transition periods, but also the risks really of people falling between the cracks, particularly when there's extra strain on the system. So I just wonder anything you can add around what you've been doing around the transition.
I would say, Councillor Holt, that we've been working for some time to try and develop those standards. And I know that they're not embedded in all services, and we're working very hard on that. But I would say there's been more opportunity to carry on with people's care during COVID. So I know of many cases now where the children's services have agreed to continue with somebody's care because of the situation that we're in currently, and it just didn't feel right to transfer at this time. So we've done quite a lot of that, I would say, more so than we had done prior to COVID. And I think there's some learning in that. So I think there'll need to be some more conversations about that based on the standards that are being produced.
I'd just like to add, Councillor Holt, in terms of not as part of our responding to COVID, but as part of our normal work, we have regular engagement with colleagues within MCC. And as part of the work that we've been developing, I suppose, over the last couple of years, and in terms of that close work around mental health at work, but also transitions, we have developed within each division that Deborah mentioned earlier, the North, Central and South Division, professional leads for social work who will be responsible for supporting people and young people in transition. And those people are now in post and are working with colleagues within CAM services and other partners to ensure that transition is improved. And we're at the beginning of that journey.
Thank you.
Thanks. Next, Councillor Quay.
Thank you, Chair. A very interesting report with lots of detail in it, and it's good to see the great work that's been done. Obviously, mental health has been a huge issue for many people over the course of the pandemic, and that those issues will continue going forward. We see a 15% overall rise in demand, and obviously we will move into a phase after the pandemic crisis of a build back better phase. So what I'm wondering is, based on historic data on periods of economic recession and other social crises, what can we expect the long-term trends to be for the demands for ongoing mental health services during that phase? Will that fall, do we think, or will it continue at that rate for some time? And how do these needs match up with our capacity to deliver them and the resources that have been made available from central governments to help us meet this demand in the future?
So I would say, as far as the modelling is concerned, we're still working that through, but what we've compared it mostly to is to recession in previous years, which I know is not the same thing, but that's the only thing we've got. And I think in those situations we saw things likely to continue for at least another 2 years to come. So I think we're not expecting this just to dissipate over the next few months. What we've got at the moment is short-term funding on winter and crisis, but what we're speaking to NHS England about at the moment is a 2 to 3 year package on both community mental health and crisis, and those are the conversations that are taking place over the next 2 to 3 weeks to be able to secure some funds for Greater Manchester. And we understand that there are ring-fence funds available for this moving forward, so we're hopeful that will come to us.
Thank you. I wonder if the executive member might want to make a comment on that as well, Chair.
I suppose all I would add would be from, I suppose, the position that we've consistently taken in the city around the funding of mental health services, and that we believe that we should be getting more funding from government put directly into mental health and wellbeing services for people in the city. I think too often we've seen some of the real challenges that come with treating people at a point of crisis rather than a preventative approach that can be had across the city. And I think the Trust have done an excellent job in the last few years since coming into Manchester and turning around the services that are available. But I think our position remains the same. Mental health services in our city continue to need more funding, and we'll be making that case to government repeatedly.
And Councillor Hitchin.
Thank you, Chair. I'd like to go back to 4.4, please, of the documents. And my question is 81% are seen within 6 weeks of a virtual contact. But I'm just wondering, what's the waiting time for the 50% who need face-to-face timing? And how does that work? Is it 6 weeks? Is it another 10 weeks before they actually get to escalated? Do you know, could you explain the triage of how that works, please? And then I'd also like to ask the question in relation to, with it being digital, how hard to reach people get there when people are in crisis and cannot afford to have phones or computers. And so I'm just wondering, how do you get to reach those hard to reach people who have access to very little funding, please?
You okay if I respond to that one, Deborah?
Okay.
Thanks for that, Councillor Hitchin. I suppose there's two aspects in terms of our engagement with service users. The first group I'm going to speak about is around our known service users, which is what that stat references to. Within our known service users, our contact isn't just digital or telephone or video conferencing. We are now currently working to a model, and have done through the pandemic, of just under 50% face-to-face versus 50% virtual. We do that based on service user choice. We've engaged over 600 service users during the pandemic to get their feedback on their experiences through the pandemic and how we've engaged those service users. We also do that on the ability a service user has. So for that great example you've given around the equipment that they have to enable to engage virtually. Some have really welcomed it in terms of feeling safe, wanting to shield and been a way to engage with their care coordinator or their community team more consistently. Some have preferred that reassurance around face-to-face, and we've had feedback around the reassurance of our staff having access to full PPE. So in terms of that, for known service users, that has tended to be our split, and we base that on patient choice. In terms of new patients, in terms of new referrals into our service, we do have a slightly different model, because we feel when we've engaged with service users, when we've engaged with our staff and our clinical teams, that we need a more face-to-face appointment first in most cases. And that is roughly, it ranges between 75 to 80% of people are seen face-to-face. We still do have a virtual offer, because we have found examples of where we are able to do that, but it's a lower percentage. So again, we offer the service user the choice within that. In terms of our access times within Manchester of referrals into CMHTs for the last 2 months, all our CMHTs access for a routine referral under 28 days at the moment. Some we have under 21 days. If it is an urgent referral for the last 2 months, we have hit over 80% of people seen within 5 days. And I think that's a real good achievement for the community mental health teams with the referrals that they've had, but there's also work to do. So I hope that answers your question. I'm happy to expand if you think I need to.
Yeah, can I just come back on that, please?
Yeah, go on.
When I was on the Health Scrutiny a number of years ago, the service users, when they were first accessing the service, it was considerably a longer wait. So, I'm really pleased to hear that the waiting time is roughly 28 days maximum at this moment in time, which sounds really good in consideration. It was like 16 weeks to get to your first appointment. So I think that's a good improvement. So I just want to congratulate you on that service improvement.
Thanks, Councillor Hitchin. We still have work to do, and we still need to work with to engage a population around within primary care and the new models of care that the community framework for mental health has designed for us, but Deborah's referenced. We're getting some support, hopefully, over the next 3 years to increase funding and support people within primary care. But within secondary care services, we're really proud of the progress we've made.
Do we have any further questions from members? At this point, wave at me or use the chat. Could I just ask, we've got a report coming up about moving towards people not just turning up at A&E and using the phone and other ways of accessing services and potentially being triaged. How are you finding mental health service users turning up at A&E at the moment? Has there been any kind of increase in that, or is it kind of where it previously has been as the first point of contact? Because it kind of comes from Councillor Hitchin's point about if people don't have the technology or they haven't got credit on their phone or whatever, there's all kinds of reasons why A&E can be their first point of contact. And I know work has been underway for quite a while to try and prevent that from happening. But has there been any shift in recent months?
In terms of that, Councillor Farrell, like the other providers within the start of the pandemic, we experienced significant reduction in terms of people attending A&E, and we, as again in line with the acute partners, we've started to see an increase in return to pre-COVID levels in terms of attendance at the department. We are working closely with all our acute partners, and I'm sure Naomi, I can see, is on the call in terms of our progress to ED by appointment. We are quite fortunate in mental health in terms of we established the 24/7 crisis line that linked in with NHS 111 really early on in the pandemic. So in terms of supporting that and progressing that work further, we're quite well placed to do that. We need to work further around developing mental health urgent care centres that we've agreed with all acute partners across a GM are being co-located within acute hospitals to divert people away from ED. So in terms of the short answer is work to do, but well engaged with the system partners in terms of progressing that. And internally, we have the right systems and processes in place to be able to progress that work.
Thanks. Okay, going back to the original report on members page 21. The recommendation is slightly different here to what we normally have. So it's not just a note, it's the Scrutiny Committee is asked to consider the report and advise on the following. 1, do the steps taken by GMMH support the strategic objectives of the City Council to address local need throughout the pandemic? And 2, is there any further information we require? Members? Councillor Quaid?
I don't think at the moment, obviously, officers are delivering and working hard on plans and stuff. So I think it's something to watch in the medium term for, gathering the data and the evidence for making the argument for further funding in the future is important.
Thanks, Councillor Hitchin.
Yes, thank you, Chair. Yeah, my question is, I'd like to see further in relation to the digital section and how that's going, because I'd like to see how, as the pandemic and people lose their jobs and access to funds is very, very limited, I'd like to see how that impacts. So I'd like to see further reports and how that is being utilised, and if there is better improvement or worse improvement in relation to the populace needing access to this service, and does digital actually work in comparison if they don't have any access to recourse to funding is very limited. Does that make sense? I'd like to see something forward because of the poverty levels that people may face in the future and how we address that. Yeah.
Yeah, that's potentially also a topic for a future report, I think, generally about digital exclusion and communications, and that also ties into the A&E by appointment thing as well, because that will be a similar obstacle. If there's no one else wants to come in at this particular point, with that request for further information, and we can work out whether that does become another item or just an update. We are happy as a committee that the work that JMMH is doing so far does indeed to support the strategic objectives and is doing what it can at the moment to deal with the results of the pandemic. Is that agreed? Thanks, everyone.
Agreed.
Brilliant. Thanks a lot for coming in. That was put together at fairly short notice. This is an item that came out of a previous meeting, so it's good that everyone's in a position to react to what the committee is concerned about and come back to us quite quick. And that, even under normal circumstances, that's appreciated, but at the moment particularly. So thanks for that. You're welcome to stay for the rest of the meeting if you want, but you've probably got other things to do, so we won't be offended.
Okay, thank you. We're going to leave.
No problem.
Thanks, everybody. Bye.
You can always watch the rest on the catch-up.
Okay.
Thank you.
Thank you.
Thanks. Okay, we are still not going back to the agenda as it was presented to you initially. I've now lost the piece of paper that it was on. We are going into item 6 on urgent care. Again, we work on the basis that members have read the report, so key bits that speakers would like to draw members' attention to, and then we'll take questions. If you could introduce yourselves as well for the benefit of newer members, but over to you.
Hi, so I'll start. My name's Naomi Ladwith and I'm the Director of Commissioning at Trafford CCG, but we're doing a joint piece of work across Manchester and Trafford on urgent care. I've got a number of team members with me from across the different CCGs and also our provider colleagues. So I've got Veronica Devlin, who's the Chief Transformation Officer at MFT, which is the acute trust provider. I've got clinical leads from Dr. Peter Fink and also Sarah Fallon. And then I have commissioners, one commissioner now, actually I was going to have 2, but we've got Kay Hadfield, who's the commissioner from Manchester. So I'm going to take you through just some highlights of the paper, and then Veronica is going to just give a bit more of an overview of the actual model. And then Manisha Kumar, who is the Medical Director of MHCC, is going to give an update specifically about the City Health Walk-in Centre as well. So just to give you a bit of an overview, so we've known pre-COVID from patient insight that urgent care can be quite confusing for patients. There's a number of entry points, walk-in centres, emergency departments, or A&Es as some people call them, GPs, minor injury units, and we kind of got to the point where it's understandable where the default is sometimes to go to the emergency departments because that's just the easiest, most simple place for people to find, really. At the start of COVID, we saw a considerable decrease in footfall into emergency departments, but it has been rising since May, and part of our ability as a system to be able to respond to COVID is trying to kind of maintain lower numbers of people that are having to attend ED and trying to find a different way to be able to support them. It's also as well, in terms of social distancing and infection control, the space is more limited. I'm sure some of you will have visited hospitals or your GPs and know that we've had to take out seats and space. So actually the settings aren't equipped to have high numbers to go through, particularly over the winter. And it's our responsibility as a system to be able to guide and support the public to have the right care in the right place and make it as simple as possible for them. So we do know that about 70% of people who turn up at emergency departments are walk-ins, and we do know a significant number of those people could be treated elsewhere if it was easily accessible or easy for them to find out where they needed to go to. From December across the NHS, there will be national campaigns pointing the public in the direction of using 111. and under a scheme called Talk Before You Walk. I've just as I was having my lunch before, I've just noticed the national adverts have started on the TV, you'll see nationally. And that also allows people to be able to be booked into slots in ED as well. So our aim is really to provide a better service, use of technology, but sensible use of technology to make sure that we aren't causing any more health inequalities, be able to support healthcare practitioners to be able to get advice and be able to offer alternatives to treatment in the acute sector, and make best use of our GPs and pharmacies and our primary care offer. And only really when necessary that people are having to go to ED, really if it's life limiting or limb limiting. And this isn't just about COVID, this is about a long-term aim. So we're trying to look to have a sustainable system that's accessible for people moving forward. So sorry, I've just got a delivery at my door as well. So if I just hand over to Veronica just to talk through the schemes, right, I just turn my camera off for 2 seconds.
Well, yeah, if you're ready to pick up.
Hello, sorry, there's a bit of a delay on the line. So the model really is in 4 parts. So from the patient's point of view, what they will see is the adverts coming out advising to contact NHS 111. And they can either do that by phone or digitally. When they make contact with NHS 111, as the first point of contact, they will be assessed from the point of view of what sort of service does this patient require, and they will be advised accordingly. In order to alert emergency departments to patients who have been identified by NHS 111 who will be coming to the ED, a system has been put in place so that a live data screen is visible from the emergency department with some clinical details from the assessment from 111. So the emergency departments will have advanced knowledge of not just the patient demographic details, but some of their clinical details as well, and they'll be able to respond appropriately as a result of that. So emergency departments already have similar sort of information that comes through visible from the ambulance service. So this is kind of an adjunct to that, if you like. So the objective really is to provide a different route in to the emergency department. When we move to the next step, there will be available appointments for patients so that we can avoid large groups of patients having to wait in one place at one time because of the infection control risk, and also for patient convenience as well. So if we can give patients an appointment slot, it'll be much more acceptable to them rather than sitting for 4 hours to wait to be seen. From the point of view of the CAS, so the Clinical Assessment Service is what provides the intelligence, and will, when the further services are developed, we'll be able to direct patients to a different service. So in the fullness of time, we would anticipate that this service will open up additional services for direct access for patients. So it's going to be an iterative process. At the minute, we have now gone live with the screens, which will show the information coming through from NHS 111. So the emergency departments have that. There is more work to be done on the available booking slots, and also on the streaming that can happen at the front door. So for patients who self-present, and a proportion of patients will continue to self-present without having gone through NHS 111, those patients will continue to be seen. But what we would like to be able to develop for them is a route that may not take them through the emergency department. So a significant proportion of patients will come, have a stay in the emergency department, have an initial assessment, and be then referred on to another specialty or another service. They may not necessarily need admitted, but they need a specialist opinion, or they need a rapid access diagnostic test, for instance. So what we'd like to be able to develop is to be able to direct patients without A&E floor space being the middleman, if you like, so patients will go straight to that specialty, and that ambulatory care service, or whatever it is that the patient needs, without having to have an intermediate step in the pathway. So over the next few months, NHS 111 obviously will be increasing the advertising out to patients. Patients will become more aware of the alternatives that might be offered, and hopefully will become acclimatised to making contact before turning up to the emergency department if it's not an emergency presentation. So a significant proportion of patients will be appropriate to be seen by a GP, or could be more appropriately seen by community services. And what we'd like to be able to do with this service is to direct the patients, having had an appropriate clinical assessment, direct to the service that they need without an intermediate stay within the emergency department. So that, in a nutshell, is the model. At the minute, all that is live is the information screens. Some of the alternative services already exist, and some elements of streaming are already in place from the front door of the emergency departments. But we would like to be able to develop that over the next few weeks and months to open up the range of opportunities that are available to refer patients direct to the specialist care they need without intermediate steps.
So sorry, I'm now back from my delivery, but if I just take us through our next steps. So as Veronica said, 111 is live. We have a clinical assessment service across the whole of GM, so it's not just Manchester, it's the wider localities within GM. And that service can hear and treat people on the telephone, as well as being able to book them into services where they can be booked into. We can book people directly into Trafford General. Trafford General went live early in November, and we're monitoring that and understanding and learning from that, and getting feedback from where patients are choosing to go to, or their needs and their requirements. We've also undertaken an Inequality Impact workshop on Friday as well, to understand perhaps the things we've not thought of, how there might be barriers put in place for people because of these changes, and looking to see how we can mitigate and support people to be able to access, but also so that we don't cause any more health inequalities. And then the next steps, just in addition to what Veronica outlined, is we need to be able to identify the pathways to be able to book outside hospitals. So just going back to the question you asked Adam before, so to be able to book into mental health services, to be able to book into community services if that's more appropriate for someone to be able to have that care, and be able to book into GP practices. Having further front door streaming happening as well, just in addition to what Veronica suggested, because people will still always, or some time to come, still walk in. We're not going to be able to switch this all off by these processes, but the ability to be able to stream and offer a similar service if people do walk in, to be able to book them into more appropriate services as well, obviously without causing people to have to kind of transport across 4 or 5 different areas. It will be done in a very sensible way. And then we've also created a dashboard to be able to understand both the outcomes, but also the kind of picture of the demand and where people are looking to go and what they want to attend. And then in December, January, there's also going to be a clinical hub run by MFT, which healthcare practitioners can phone into and get urgent advice and guidance, so that they may be able to manage the patients that are within their care in different locations by talking to a specialist. So as I say, the comms, we're doing a bit of a soft launch of all of this at the minute, just testing the systems and making sure they work and getting feedback. The national comms has started today, very gentle comms around, phone 111 first. It doesn't go into the full detail of what we shared with you today. So the ask is that the committee note this report, and obviously we'll listen to your feedback. And I don't know whether you want me to pause there for questions, or it would be better to run Manisha's, I think it might be better to run Manisha's presentation onto the back of this, and that because it's linked, but I'll take your decision, Chair.
Yes, I think it would be better to run them together because I think it makes more sense together.
Thank you, Chair, and apologies for the late addition of this piece of work to today's scrutiny, but we've had an urgent request from our city centre walk-in centre that very much mirrors the challenges that our emergency departments have had, and a request to have a similar talk before you walk model for city centre. And I just wanted to give you a bit of the background of some of the challenges. So the city centre walk-in centre is having real issues with overcrowding in the estate that they've got. The City Centre Walk-in Centre is a large primary care centre which has got a registered list of about 13,273 and has a high prevalence of sexual health, young patients across GM and not just in Manchester. The issues that we've had is that since lockdown has lessened, is that with COVID secure arrangements, they're really struggling in order to get the throughput of patients in a COVID secure way. The services are co-located on the second floor of Boots the Chemist in Market Street, and they share their facilities, so entrances and lifts with the Boots store, the ophthalmology and dental services. And patients attending either the registered service or the walk-in centre need to utilise a shared waiting room in that area. Now that's only designed to hold 20 to 25 patients. However, with social distancing and the increased demands for the walk-in centre and the GP practice, as we are encouraging our patients to come in to make sure that we've learnt from the lessons of the first lockdown that urgent care must be dealt with, is causing significant issues. So the numbers that we've had in April was 671 patients per month attending the walk-in centre, but by October that had gone to 2,288, so significant increase, and they were really struggling with safe waiting. And with that extended queue and extended waiting room, there's a risk that the most vulnerable won't wait in a complex arrangement, also with regards to the risk of infection in those areas, but will move elsewhere and therefore won't get the care that they want. The real anxiety comes as we move out of lockdown into our tiered solution. So as of tomorrow, that non-essential shops will open again, but more importantly, as we move into tier 2, with bars and restaurants reopening, what they would like to do is rebrand to a talk before you walk model similar to our emergency departments. So patients will still get the care that they need. They will still have the walk-in centre unscheduled part of the offer, but they'd like to rebrand it to call it something like a Manchester Urgent Care Primary Care Hub. They'll maintain their operational hours. The access will be a direct telephone number to the facility, so it won't be via NHS 111, so there won't be an additional layer of contact. The patients will be spoken to and they'll be given a time to come in to wait in the walk-in centre waiting room, which will allow us to stagger that flow and make sure people can sit and wait safely, and we can make sure that everybody's had that urgent consultation. This will also allow those who are vulnerable to be allowed to sit and wait for that walk-in centre element as opposed to being lost in a larger number. The request is that we do this until the 31st of July 2021, which is the end of our current contract with that walk-in centre, and hopefully will allow us to get to a more COVID-safe way of life as the COVID vaccine comes into play over the next few months. Thank you, Chair.
Thanks. It's appreciated letting us know about that as soon as you have done. But while we ponder the implications of that, I'll go back to my questions list, starting with Councillor Newman.
Thank you, Chair, and thank you, NHS colleagues, for your presentations and reports. It's quite ironic, really, what we've just heard about the walk-in centre, the city centre above Boots. The elected representatives of Manchester people, this committee, and a number of us who go back to a few years an involvement on Health Scrutiny Committee, as some of our NHS colleagues will know, we opposed very strongly the closure of walk-in centres, and we pointed out that one of the consequences of the closure of walk-in centres would not be, which is what the NHS wanted, that people would instead go to their GP, but that there would be a much bigger increase in people turning up at accident and emergency departments. And that, of course, was a contributory factor to the overcrowding and the increase in A&E departments. Anyway, that's history, as it were, but I think it is relevant. And of course, the one above boots was kept probably partly because there was a recognition of its need, but also because it was a contract with a private provider, and therefore certainly at the time when the NHS was closing walk-in centres in Manchester, it wasn't possible for them to do that because they still had to pay the private provider. It may have been renewed since because of the obvious demand, but I think that what we've just been told in the context of COVID and the pandemic, and obviously makes some sense. I think it's a shame, but the last thing that people need is to be going to a walk-in centre and picking up the virus because of overcrowding, because it's not practical to provide a COVID secure waiting environment. And as the doctor just said, some people turning up and looking at that might then just walk away because they don't want to take the risk of picking up the virus. So I think probably the proposal there makes some sense. I'd be interested, I'd be hopeful. I'm not got an interest about a contract with Boots, but I would be hopeful that once the pandemic is over, hopefully by July, that a walk-in centre does continue in the city centre. And I hope that will happen, but that's for the future. In relation to the general proposals in the report, I think, again, in the context of the pandemic, I think they make a lot of sense. I know that as of today, I think it's sort of coincidental in relation to the ending of lockdown, but as of today, we're told in the report that the digital booking solution is in place for bookable appointments. So obviously it's too early to say how that has gone, but what has been in place for a month since the 4th of November is the clinical assessment service. So I would be interested to know what's the initial feedback over 4 weeks of operation of the clinical assessment service, albeit that it's not been able to be linked to a digital booking system, but clearly it's being linked to NHS 111. My other question is, and again it follows really on the point that Councillor June Hitchen was making on the mental health report earlier. There will be plenty of people who have difficulty accessing NHS 111. Digitally, they may have difficulty doing it. Clearly, it's very important that if they phone up 111, that is answered reasonably promptly, and that the person at the end of the phone knows what they're doing, and can clearly, in the case of the clinical assessment service, make sure that information is passed to that service, and that they then phone back the individual who's worried and thinks they might need to have to go to accident and emergency, that they're phoned back promptly. Again, there will be issues about the difficulty of people being able to explain things even over the phone, in terms of it's not face-to-face, so there's going to be clearly practical problems there. But having said that, I completely understand the last thing we want in what were already overcrowded accident and emergency departments, partly through the efforts of this committee, the late MP Paul Goggins and the current MP Mike Kane. The Wythenshawe Hospital Accident and Emergency clearly has had major investment, but there are still issues there, and clearly there are major issues at the MRI in terms of the amount of space that's available. And no doubt there are other issues at North Manchester. So that was all prior to the pandemic, but now with the pandemic and the fact that people are now beginning to go back, that has to be handled. So what you're putting forward probably seems to make general sense. You pointed out both in the report and in what you've just said about what you've described as the hospital streaming at the front door, a sort of very primitive level of triage to try and assess, that people don't go in COVID areas and that they are sent to the right place, because people still will turn up. But the detail of this, how it's implemented, is going to be so important. The messaging that you're going to put over must still be, I think, if you've got a life-threatening emergency, you phone 999. You don't mess about with 111. But there will be people who will phone 999 or be waiting a long time for an ambulance, and in the past would arrange for a family member or even a taxi to take them to the A&E department because that seemed quicker than an ambulance. So there's issues like that. There's a lot of detailed issues that have to be looked at here and how it works in practice. But I'll finish by saying this. All this is going to be tested under the pandemic conditions. But once the pandemic is over, I hope that I'm not suggesting we go back to the previous situation, but I hope still that lessons are learned to ensure that even when the pandemic is over, that people get proper access to the A&E departments when they need it.
Before we move on, were there any specific questions there, or were you seeking comment?
Oh, well, yeah, I made comment, but I also asked questions in relation to how the clinical assessment service has been operating in the last month. That was a specific question, I think.
Okay. Thanks, Councillor Newman.
So I think it might be helpful if I come back in on that, because we haven't publicised the clinical assessment service, so it's kind of been more running in shadow form. But what I can tell you is the activity that's been happening at Trafford. So in Trafford, we have seen about 83 calls a day at Trafford General, with 70% of those being able to be managed within Hear and Treat. We haven't had any complaints or issues or response back from patients. But we have also said, considering we said the whole of Trafford is about phoning 111 first, so long as you don't have a life-threatening or limb-threatening condition where you would phone 999, still 50% of the activity is people walking in as well. So people are still choosing to walk through, and the service is still managing it. But we're seeing quite a lot of support being able to be given virtually to people through the CAS at the moment.
Thanks. Councillor Wills?
Thank you, Chair. And thank you very much to everyone for this update. I mean, it is unfortunately necessary, given the current conditions, if A&E departments are not to become completely overwhelmed. I guess my only concern, obviously it's gone live today, is I'd like to hear a bit more about how this is all being communicated. I think particularly to older people who are less likely to be online, people with learning disabilities, people whose first language isn't English. So is this being communicated in language? Just to make sure that, to all groups who may potentially be missed out by a completely online strategy, to make sure that everyone is getting this message. So it'd be good to hear a bit more detail about what's being done in that regard. Thank you.
So I'll start off, but I might bring Shan in. I'm going to look at Shan too. Yeah. So we ran an equality impact assessment workshop last week to answer a lot more of those questions, and we'll have a plan to be able to kind of target and support people who are most at risk around suffering from inequalities as a result of this. However, we also do have a full communications plan, and Shan will be able to give us a little bit of an outline of what we're doing around that.
Hi, yeah, in terms of the communications, it's a very soft launch that we're doing on the communications so that everything is in line with the national messages. I think the first thing is to just completely reiterate that at no point will anyone who feels that they need to attend an A&E department be turned away if they need to enter. So if any patient turns up and they've got any issues with accessibility or problems contacting 111, or need to be in the hospital at that stage, no one will be turned away. So there is no suggestion of that. A lot of work is being done on engagement with various community groups, etc. It's all been worked through quite quickly, this piece of work, as a lot of things due to the pandemic. So what we're very conscious of doing is that we make sure that those equality and mitigating actions are iterative and we move them forward. So as Naomi said, we did a big workshop between all of the organisations last week to make sure that as the team that we are, there's nothing that we've not thought of. We're just working through all of that. And then a further programme of engagement will be happening, maybe with smaller community groups and specifically affected community groups, especially around BAME populations and those communities that have had increases in, what's the word? I've forgotten the word. Increases in disproportionate equity for health services during the COVID pandemic. So we will make sure that we do further engagement with them. In terms of the comms plan, I'm sorry, Naomi, I need to go and look at the detail. As I say, the national campaign has started today. Local campaigns are taking place over the next few days, but it is a very soft launch so that there's not a big bang feeling that people suddenly think that they're not able to attend A&E. They will always be able to attend A&E. So it will be a drip feed over the next coming weeks and months. I hope that helps.
Thank you.
Thanks. Just before we move to the questions, rather than going back over ourselves, it was a question that came up before the meeting. Councillor Monaghan made, whose video's not working, about the publicity on this, because it seems to be like a new scheme that's starting today, and we wouldn't have known about it had we not been on the Health Scrutiny Committee and been reading our papers. It's unusual to launch what's actually quite a major culture change, because people have previously always expected that you go to A&E and you might wait quite a long time, but you don't have to do this. This is, quite a new thing. And normally with something like this, you'd expect people to know about it in advance, and you'd expect to see messaging and advertising. Normally with kind of medical and health things, surprises aren't great. There was an orthopaedic surgeon in 19th century Liverpool that used to jump out at people from behind a screen and reset their arm. And that was seen as quite an advanced use of surprise in a health sector. But otherwise, if you're not going to commit a crime or catch a criminal or be the Spanish Inquisition, surprise and people not expecting major changes isn't that good a thing. Councillor Monaghan, do you want to come in with your question?
Thanks, Chair. I don't know whether you can hear me. My screen went off when I had to answer the door.
Yeah,
can you hear me? Yeah, I put it on the chat. I was just wondering about what did I put in the chat? How will it affect the waiting times of A&E? Will hospitals still have to meet them? And how have the trials gone so far? Has it already started in, is it Blackpool and Warrington? Have they tried it in their hospitals? I just wondered if there's any news on that. Thank you.
So Veronica, can I bring you in on the performance targets? The short answer to that is yes. The hospitals will still have to achieve their targets, but Veronica will know a bit more detail.
Yeah, so the hospitals will still have to meet the targets. The patients who are seen within the emergency department will still be, subject to looking at their 4-hour journey time, etc. But what we're trying to do is make sure that the we have the space and time to be able to deal with the patients effectively as well. So as this develops over time and more patients are being managed through an appointed system, it should take pressure off the system overall. So I think it will be very difficult to see in the early stages, but as we increase the numbers of patients being seen in the appointed system, it should give much more control over peak times, making sure that we can manage our staffing according to the patterns of patient attendances, etc. And we'll have much more control over it, I think. It's not something that is going to have an immediate impact. It's going to take a period of time for these changes to work through and for people to become familiar with using NHS 111. I think that's one of the challenges. There have been lots of attempts over the last probably 10 years. So I was an A&E doctor for 23 years before I did this job, and there have been numerous initiatives over the years to try and manage particularly walk-in emergency department attendances in different ways, and to change the patient population's behaviour by using advertising, by using various kind of methods of persuasion, and they've all had variable degrees of success. And I think one of the reasons why the soft launch is a good idea is because at the minute nothing visible will change for the patients. Over the next few weeks and months, they will start to see national comms, which will be locally tailored, that will help them understand how they can access their healthcare in the future. So they've already started to become accustomed to virtual appointments for outpatients and for primary care, for instance. And I think people will see this as another step in that direction. It allows patients some more control over it too. So I think there are disadvantages to having the soft launch, but I think the advantages outweigh it overall. I think patients will see a gradual change rather than a very sudden change, which would be much more difficult for them to cope with, I think. And I think there would be a risk of them feeling that access had been effectively blocked to them for the emergency department if all of a sudden this initiative comes out. So they shouldn't really see the change today. Over the next few weeks and months, they will start to see a change in how patients are directed and which services that they can access more directly.
Okay, so it's a very soft launch, really, isn't it? That people might find out about it by accident, which is, yeah. Okay, if the committee will indulge me a bit longer, A&E by appointment isn't a new thing that's just come up, is it? It's been knocking around for a while. So although we're talking about it today as a response to COVID, and as Councillor Newman pointed out, there are certainly COVID-related reasons why you wouldn't want full waiting rooms and people coming in that don't need to, and all the rest of it. But how long has moving towards A&E by appointment and triage or whatever, how long's that been looked at by MFT? Because I've seen reports from several months ago. So I think we need to be quite clear that if this is a thing that's been on the horizon for a while, that there may be an intention to keep it after next summer or whenever, and we're starting on quite a long-term cultural change and expecting quite a permanent behavioural change in what patients do and how they access care. Are there any thoughts on that from speakers?
So, appointed emergency departments have been discussed for a number of years. So the Royal College has had that under consideration, and I think it's fair to say there are differing views in the College of Emergency Medicine about how effective and how manageable it will be. I think COVID has really stimulated the same kind of discussions as we had about virtual outpatient appointments. That's been kind of bubbling around for a number of years as well, and COVID has really provided the impetus for a lot of organisations to really go for that and embed it. I think there are very valid reasons why elements of this model should stay in place in perpetuity, because there are patients for whom there is no need for them to pass through an emergency department, and currently it can be a kind of a filter for access for other services which could be directly accessible to patients just now but aren't. And so I think we've been struggling in the acute sector in general, not just in MFT but across the nation, in terms of how we secure direct access to things like ambulatory care, for instance, for patients, without them having to go through an additional first step that might take 4 hours and doesn't necessarily add any value. So I think it's about learning from how this process proceeds, taking feedback from the patients and understanding which parts of this model work and which ones need to be refined. The ultimate objective is to try and get patients to the care that they need in the shortest time possible, and at the minute with the least exposure to other people. That's kind of what it boils down to. And if we can remove some of those barriers to care by permitting patients to have direct access, that really has to be good in the long term. And not all of that care needs to be provided within the floor space of an ED. Those services already exist somewhere else, either in the hospital or in the community or in primary care. And this is really about helping patients to access that first time.
Could I just add into that as well? So moving towards booking of urgent care is part of the NHS long-term plan. So, you know, for all the reasons that Veronica has just said, and it's also about moving to more integrated urgent care, so joining up all those bits of urgent care we have to try to make it less confusing for people, and therefore give more access and make it less complicated. COVID really has provided a platform for us to be able to come together to do this more easily. It's not that we've just jumped on COVID to do it. It's, you know, it's helped us do it. But I think the thing I'd like to add to this is we are working really well together across Manchester. So I'm Trafford CCG, working with Manchester in partnership with the clinical leads on this call. We're working in partnership with MFT. We're engaging with our populations. We're working with our local politicians, and we are making sure we're trying to do the best for our patients. And as Veronica said, it's about measuring and looking at the impact and making sure we're doing the right things. We're not doing the sake of it being in the NHS long-term plan. We are looking at the outcomes to be able to shape how the services will look in the future and listening.
Thanks. Councillor Hitchin.
Thank you, Chair. Sorry, I had trouble trying to unmute then. I've just got a couple of follow-up questions, please. Front door screening. It does state, you know, like that there would be triage if somebody, you know, turns up. But one of my questions is that they would, on part of it, they would be sent back to see their GP or to a chemist or anything of that nature. What concerns me is that some people don't have access to GPs now. It's telephone conversation at this moment in time. Very, very rare can you actually get a face-to-face appointment with a GP, especially in the ward I represent. It's few and very, very far between. So I'm concerned that patients may be, and people may, and my constituents and people in Manchester, may have already been suffering in silence, trying to get a GP appointment but couldn't get it, not been seen by their GP, feeling very unwell, get to the A&E but don't come by ambulance, and then don't quite articulate what the problem is, and so they're not seen by a GP, by a doctor, and being told to go back to see their GP. So I'm a little bit concerned about the delay in that process. So on that point, my other concern is in relation to some people may, for instance, have a break a limb, but it doesn't quite show up, and like you'll ring the 111 and it doesn't have the right symptoms. So your foot may not be swelling at the time, it may not be bruising, it may not be any of those things, but it's a little bit painful, it's a little bit niggly, but it's not anything that you would actually think, oh, it's broken. So they wouldn't phone an ambulance, but later on it feels a little bit more. And because they haven't come into ambulance, will they again be turned away because it doesn't meet that same criteria? And then my final question is in relation to what's been done. Now, you said about 4 hours and etc., like for waiting lists and things of that nature. However, that only starts if a patient is going to see a GP, to be able to be seen. What happens to all the ones that have been turned away? Are they counted as well? Hopefully people will be able to answer a few of those questions, please.
So, Manisha, I was going to say, do you want to come in?
I'll happily come in on primary care. Council Hedge and primary care is open and has been since the beginning of the pandemic, and I've gone on every opportunity to say that. We've done over 400,000 face-to-face appointments so far this year. Yes, we have to operate a virtual or telephone first offer because that's the only way we can safely get people in, and it's for their safety as well as the fact that we now have to wear full PPE. So a face-to-face appointment isn't the same as it was either for the patient or for us, and actually it's quite difficult as a GP to have that same rapport when you're fully gowned up. So if there are people who are struggling, please do let us know who they are and we'll help them navigate a new system, which I think is harder. But I have to reassure you that if a patient does need to be seen face-to-face, they will be. But not everybody who wants to be seen face-to-face can be in the timeframes that we've got. But if there are people who feel their care is deteriorating, we'll happily take that up with you outside of the meeting if that would help.
And others may want to come in this as well, but in terms of the streaming at the front door, it will be really sensible. You're talking about clinicians doing the streaming at the front door. It won't be as black and white as you've walked in, so therefore you aren't suitable to be seen in A&E. They will deal with people really sensibly. We're here to care for people, and the whole premise of this is to make sure the care is delivered in the right way. In terms of if people are signposted to the GPs, they will be booked in as well. So it's not just, off you go and sort yourself out again, which will be very frustrating. I can imagine myself as a patient being very frustrated in that. And in terms, and Veronica might want to clarify on this, but in terms of the numbers of people where we stream and maybe people are booked into other services, we will be counting those numbers and monitoring those numbers of patients. And we also have a requirement to monitor where we perhaps have booked somebody into a service and then they did not attend it. We call it DNAs, and actually to follow that up because we don't want people to get lost in the system as well. So really key to this is measuring and following the patient's journey and listening, going back to what Shan said at the start, this is going to be a journey over a number of years. It's a cultural change. It's a change for everybody, and we've got to be able to listen and learn from it. Veronica, I don't know whether you want to add anything. Oh, go on, Kay.
Yeah, it was just around the injury point that was raised. So if a patient has obviously injured themselves and it gets worse and they go through 111, they will actually be booked directly into that illness injury stream rather than going to A&E and waiting. So those algorithms, they won't just say stay at home. They will be seen just because we're not going via an ambulance. They're a lot more refined, and also the clinical assessment service are clinicians that can pick up those calls that might not be sent to go directly to ED. They will actually do another clinical assessment with the patient, so then they can put them into that injury stream. So hopefully they will be seen quicker than actually going via A&E.
So just to pick up on the question about streaming. So the clinicians in the emergency departments are very keen to manage the risk. That's what A&E clinicians do. They're experts in managing risk. And the last thing that they would want is for a patient to be misplaced into the wrong service or to be, you know, diverted from the emergency department when they should be seen within the A&E service. So a lot of time and effort has gone into trying to refine the streaming model and to make sure that patients are directed appropriately. And what happens now in a lot of emergency departments is if a patient arrives and they have a primary care appropriate attendance set of symptoms, they will be given advice and they will be redirected back to primary care. And that happens now. That's not any different to, you know, to what we're going to be doing in the future. If it's appropriate to be seen by primary care, then it's appropriate. I think it's how that transfer of care is managed. And obviously every patient is an individual and you have to take into account the patient's age, their ability to understand the instructions they're being given and all of the rest of it, how much pain they're in. All of that will colour the approach that's taken by the clinician that sees them. But just to assure you that a huge amount of time and effort has gone into thinking about how streaming and the triage at the front door can be as safe and as robust as possible. And the people who'll be carrying it out are specially trained to do that. It's not just anybody, any member of staff who can undertake those roles.
I think you're muted, John. If my video worked, I would shake my head at you, but my video doesn't work. You still can't hear you.
Oh, I've be on mute.
We can now.
You can now. Oh, that was the internet. That wasn't my incompetence. Wish to point that out. I've got misgiving slightly because my experience of using 111 was a couple of years ago for a family member, and it wasn't straightforward. So I'm hoping it's improved since then. But at the same time, that family member would tell me on the phone if they'd injured themselves, and would tell a nurse or a call handler that they weren't that bad and they weren't in pain, and it was all fine. And it would only be if you could see them face to face that you'd realise that wasn't true. And they're in worse condition. So I'm a bit concerned about that. But on the other hand, I still have nightmares of 20 years ago when I broke my hip slipping on ice. And because I was like 21 and walked into A&E, albeit with someone on either side of me, then it couldn't have been a broken hip. And I can still remember being made to walk up and down a corridor with a broken hip to prove it wasn't one. So sometimes, yeah, even if you get to hospital, and that also wasn't a Manchester one, but it's not always ideal. So I can see the issues either way. Councillor Quay.
Thanks, Chair. I think, as you've just mentioned, one of the things that's really important here is that we're all kind of conditioned by our pre-existing experiences of NHS care. And while we're all huge fans of the NHS, some of the things that many of us would probably feel it doesn't do so greatly or hasn't done in the past is, number one, kind of seamless interoperability of different bits of the health service. And so if you're going to deliver that, that is a huge undertaking to make that work well. And also it's the transfer of data between different bits of the health service. Now, obviously, you know, the last Labour government tried to get a single health service record, and that was unsuccessful at that time. So I guess what I'd say is that where we do, you know, whatever you do here, once you roll it out, my personal experience as a kind of person who's fortunate enough to be in the occasional user bracket of people that use their NHS very rarely is, I don't want to go in A&E at all. I really rather not do it. But experience conditions me to understand that when I do actually wish to use the health service, it will be something that is of some severity, and that the best place I can go to be guaranteed to get it dealt with is A&E. And the reason, as Councillor Farrell just mentioned, is I've had experiences with 111 in the past, phoning them up, phoning the GP, waiting for a call back, being directed for an out-of-hours service, which then it turns out doesn't exist or only exists in Tameside or Pennine Trust or, et cetera, et cetera. Previous occasion where on a Saturday at 11 o'clock, I've been getting in touch with the doctor, being advised that I can have a out-of-hours appointment at a centre at 3:30 in the afternoon, going to that, and the result of that was being told that I then had to go on to A&E, and then we're getting into evening time on a Saturday. So my experience would have told me that if I'd have known in the first place that I would end up in A&E, I would have gone at 11 o'clock in the morning, not at 5 o'clock in the afternoon when we're getting into peak time. So, we need to be really clear that whatever we encourage people to do, if they use these routes and they end up being misinformed, confused and let down, and then resorting to A&E, what they will then do is they'll lose trust in this new system, and they will do, as many people currently do, is they'll just either not bother or they'll go, oh, I better go to A&E, and that kind of defeats the whole object of what you're trying to do. So, that is really, really important, and I'd love to hear any information you've got on how we're going to ensure primary care and hospital services share data in real time to prevent unnecessary duplications and diagnostics and hand over relevant information with the 111 service. And if you can do that, that's fantastic. And it sounds great in theory, but obviously it's quite difficult to achieve in practice, and very ambitious project that we've got here.
So I won't be able to kind of produce stuff off the shelf to show you today, but I think you probably described our challenge really well. It is about having integrated urgent care. It is about all parts of the system talking together. It is having IT and records that talk together. So the system that's supporting the CAS and the 111 and the booking into the different services is all the one system. I'm not an IT expert, so I won't be the one to be able to go into the detail with you, but that is the challenge, to make sure we ask the questions once and get you routed to the right place, and that you have confidence in the NHS. And I think the only assurance I can give you at the minute is that we know that, and we are working together to do that, and we understand the importance of information and data within that as well.
That was me not muting this time around. Councillor Curley, who is on mute.
I think I'm off now, Chair. Yes, this is a fascinating debate, and it's really, really interesting, one of the most interesting ones that we've had for some time, only because it makes a mega impact on the people we represent. And as I read through it and as I listened to the debate and what other colleagues have said, it makes me think very deeply about it. And on the very last point raised by Councillor Clay, we know that IT never works first time. It's one thing we're absolutely guaranteed on. We're experiencing it this very minute in the town hall. And, if we cannot run something, and we are doing very good, over the last few months, we've made great progress with our Zoom meetings and virtual meetings, and everyone is very pleased with that. But it's not the sort of standard you'd want to rely upon if you had an emergency, a medical emergency. So I had a general question, Chair, about access to all of the different bits of the system. And I know from my own experience and from people I represent, there are a number of GP surgeries, and when you ring or walk in, if you're in the area and you haven't got any credit on your pay-as-you-go phone, invariably you're told by the staff, our GPs do not do face-to-face events. So could we please have something go out to say to people, and it's the managers of the GP surgeries, they need to know that that's really very bad information to be giving. They wouldn't say or don't say, and in my own personal case, it wasn't explained to me, no, you have to do an event first on the phone, until I really push them on it. And then, yes, they have said that. Right, that's what they should have said in the first place. So that brings me, Chair, to this whole concept of access to these services. And the gatekeepers on all of this system is the people who are going to be employed at the centre, wherever they are, whichever takes the lead on opening the gate, allowing people through. If they are not committed, well-trained and well-respected by the employer, then it's not going to work. It's easy. I agree with almost all the stuff that's said by whether it was Veronica, Naomi, Veronica, or Kay or one or two others. I've missed a couple out, I'm sure. And once you get to the medic, you've cracked it. It's getting that far is the issue. And that's why people go to A&E, because it's opened, and if you have got a catastrophic disaster going to happen in the next few hours, at least you have medics around you to save you. Chair, I am going to bring my remarks to a close, because other people need to get on with doing things. But, you know, it's all to do with me. I just think, how is this affecting people in my ward? And it will affect them greatly, because we have a socio-economic group who's going to be severely affected by it, not just in my ward and other wards in the city. We're going to have people who are complex families are going to be really struggling with this. And I think we are also going to have another group, which is people with mental health, who are going to struggle. So the lines, if you can imagine making the phone call to gain access, are we going to have, for example, language line use there? Are we going to be able to deal with people who don't have English as a first language, but do have a medical emergency? And how long is that sort of going to take to access? I know there are organisations nationally, and you can have a language line access to 100 different languages, and you're talking about 10 to 15 seconds. So I'm assuming that that's still in place. But our experience, and the reason we have, final point, Chair, the reason we have so much anxiety about this, it is a major change. We absolutely support the comments of everyone about protection of ourselves and the people who work for the NHS and all other medics, chemists, pharmacists, and all of that. But we do need to think about things that are not working, how we're going to fix them and address them. And we need to make sure that we have some sort of facility still operational in the city centre, because the one in Market Street, that walk-in centre that was really controversial when it was suggested to close, and we had a great fight, and we were right to put the arguments together to keep it. We would like to see that sort of thing retained. Sorry, Chair, I've gone on a bit. Thanks.
Don't want to come in on that?
I suppose, yeah, I can, and I think Manisha, you might want to come in as well. So, you know, self-presentation to these departments will still be there. That's the reason why we've done the soft launch, so that it didn't feel like we were switching everything off. For all the reasons you've just said, Councillor, to be honest. 111 absolutely does have to work. And there's been national work around 111 and recruiting staff and ensuring they're trained, etc. However, we need to monitor that. We need to make sure that it's doing what it's actually said on the tin, really. The other elements we need to look at is what I mentioned before around, we have to continue to make sure that we're looking at the equality impact assessments and we're tailoring services so we don't cause any more inequalities. And for me as well, it's that measurement and seeing where people are going to, what their feedback is, and that we're continuously improving these services. So this won't be just a one-off. This will be us working together as a system over the forthcoming months and years to be able to do this. And for me, I do get the concern around ED, but ED isn't necessarily the right place for everybody. I know that people think it is. So our job is to be able to give good access to alternative healthcare provision that is just as good. And that won't be in a week, a day, or a month. It's going to be over a period of time, but I think we've got the platform to be able to do that now together.
Thanks. I had an indication from Councillor O'Neill.
Yeah, thank you, Chair. I've listened very carefully to the people that obviously are trying to put this into place. But let's be honest about it. 111 is an absolute disaster. It's gone from bad to worse. Now, the other thing that seems to come across is people are more interested in reducing the 4-hour waiting times rather than looking at patient care. That's what we all should be supporting, patient care. Now, staff within A&E and within the NHS have done a brilliant job. Unfortunately, there are a lot of issues like COVID that have come into play. But you've only got to look at the issue about GPs. You've got to be nearly dying before you can actually get a face-to-face with a GP. And that is absolutely disgraceful. There is no way that is acceptable to anybody in the wards that we all represent. Now, to me, this is about a cost-cutting situation. We go through it year by year, month by month, and at the end of the day, what guarantees have we got that this is going to work? Because as I say, I put down 3 things that, in my opinion, need to be addressed and need to be addressed drastically. The 111, the 4-hour waiting time, which is why you want less people in A&E. Let's be honest about it. Let's be open about it. And staffing levels. Why do you want to reduce your staffing levels? Thank you.
Just before anyone answers that, that scrutiny is an opportunity for members to express personal views and experience. I don't think anyone else in this meeting has been quite so negative about the work that some of our partners in the health service are doing, even though we may have misgivings about aspects of it. I think that's quite important to note. It's certainly not my experience that while the current situation's not ideal, it's not an entirely negative thing. But if anyone does want to respond to that.
I will, Councillor Farrell, unless Naomi, you want to go first?
I'll go first and then you can come in about the GP. So I think you're right. I think we need to look at 111 and make sure that it's up and fit for the challenge. And as I said in the previous answer, they have looked at this nationally. They're looking at, they have recruited additional staff, and it needs to work. And we can't be routing people through something that doesn't work. So we have to keep an eye on that. In terms of patient care, it really is about patient care, because an emergency department, particularly in the middle of COVID, is not the place for someone with a primary care complaint or someone who could go directly to have a minor injury looked at somewhere else. In terms of cost saving, this is costing us more money. It's not saving us money. In terms of the 4-hour A&E target, yes, it is a challenge for the A&Es to be able to achieve the 4-hour A&E target. And what we're trying to do is find alternatives to be able to provide opportunity for people to be able to get access. And it's not because we're reducing workforce, it's a really difficult workforce to get. So it's really hard to recruit really highly qualified nurses. It's really hard to recruit ED consultants. It's hard to maintain the workforce. So this is not about reducing the number of staff. And I think the most important thing is we've got to make sure this is right. This is really about patient care. This is about caring and making sure people are supported well. So as I said in the previous couple of answers, we need to measure and we need to be able to listen and we need to be able to adapt to be able to make that work. And I'll let Manisha come in about primary care.
Thanks, Naomi. I think I just felt a little bit sad as a practicing GP. So I see patients every day I'm in. My life pre-COVID as a GP was much easier than it is now, because often I'm doing things 3 or 4 times the amount of staff that we've had to put on, the hours they're working in order to do things in a different way, but also the level of risk that we feel by working with some of our patients who would prefer not to be in surgery. They would prefer not to put themselves at risk, and our most vulnerable don't want to come anywhere near us. So we're trying to find a way to give them the most effective care. No care system or any system, I think, will be perfect. But I think Naomi's right. What we need to do is listen when it doesn't go right and learn from that and put changes in. And I think we have made headway with primary care in the last 5 years in the city. I still think there's things we could do to improve. And COVID's been a real testing point for all of us about how we can work differently. General practice staff are patients too, and unfortunately we have had people who've had sickness, they've had COVID themselves, they've had their family and their children who've been unwell. So it has been really challenging, and I hope that the experience that the majority have goes well, but really happy to learn from when it doesn't and try and make sure that that never happens again a second time.
Chair, could I respond?
You're still muted, John.
Chair, could I respond?
If it's going to be in the same tone and negative and attacking mode as the last point, I think I'd rather we move on, to be honest.
Could I say, first of all, I wasn't attacking.
Well,
I was making a valid point, and valid points about 111 has gone from bad to worse.
Well, again, if you have particular examples of casework and residents that you've spoken to, then they need to be fed in either to Councillor Craig as the exec member or to officers so that they can be dealt with, or to our partners, because just launching into everything's terrible without being able to... officers can't respond to points like that scrutiny meeting.
My sister-in-law passed away on a pavement because Barbara, who is the sister, my wife, actually tried to ring 111, and she was told, "I'm sorry, the situation at this moment in time is we'll be at least an hour to 2 hours." So in the middle of the night, I got up, drove to her place along with Barbara, and we put her in a wheelchair, and as we got to the ground floor, because she lives in a flat, she collapsed and died.
Well, that counts.
And all I'm saying to you is...
That's an incredibly traumatic thing.
Well, exactly, and you're telling me that I am being negative. I'm not being negative.
That's a particular casework issue, which I hope you did take up at the time.
No, I didn't.
Well, that's not what this meeting's for. I'm afraid.
I'm not.
Councillor Craig, please.
Thanks, Chair. So I suppose I just wanted in a slightly different vein to touch on a different point, and I think everyone accepts the pressures that the NHS have been under, particularly since March, and that there will be things that might not be ideal or optimal in terms of how services might be delivered. I suppose the thing that strikes me is that a key way forward on this item is to ask for MHCC colleagues to take some of the concerns that have been raised today and monitor that throughout implementation, and perhaps ask for a future item to come back once things have calmed down with COVID to see whether or not some of the concerns that the committee have had, which I think many of them are very valid and come from a place of experience over the last number of years, but to see how much of that has come into play in the future months, what would remain in a permanent system going forward, and what would be stood down once things slowly begin to return to normal. I suppose I also just wanted to add that, you know, if we look at, and I don't want to get into lengthy discussion of this item because there's still another item to come, you know, but the incredible work that primary care is going to be doing in leading the vaccination programme for this city and across the country will also put incredible strain on a finite resource. And I suppose what I think is useful is that there are things in this report that didn't necessarily, let's just say, wouldn't necessarily be aired in other places, either in Greater Manchester or across the country. So I think the honesty that we've had today has been really useful. But I would suggest that we come back with a future report to see how some of this has gone. And I suppose I would just, since we're all sharing anecdotes of late, I would add a bit of positivity. I've often been very sceptical of 111. I have been very quiet about this because I felt like a bit of a pillock, frankly. But I had to visit A&E with a broken foot, and I've had to have follow-up in a COVID lockdown. And I think some of the concerns around access that I had around primary care and other services, thankfully, haven't come to roost. So it's very hard at the minute. I know it's really difficult. And I know as councillors, we all hear things from residents that are really either ranging from frustrating to angering. So it can, you know, things can become quite personal and quite heated. But I just think, you know, the overarching discussion in this committee has been really positive today, and recognises the great work that many of our medical and NHS staff in the city deliver.
Thanks for that, Bev. That was common sense.
Thanks, Councillor Craig. I've got one final indication, if it's brief, from Councillor Ali, who hasn't spoken yet.
Thank you. All I wanted to say was I know that the system was struggling right at the beginning of COVID, but I've had to go use the services a couple of times because I've got two younger accident-prone children, and I've got to admit, even having sort of the contact via phone and things has been, they've dealt with it really, really well, and I've had quite quick responses. And to be honest, in the circumstances we've got and the struggles that they are, you know, that are happening to try to provide a service, they've been really, really good. And for once, I've got to admit, I've got to compliment the NHS because they've actually delivered for when I've needed them as an emergency for my two young ones. So that's all I wanted to say. It was on a positive note.
Thanks. Okay, we are going to have to move on this now. There's probably some. I'm just checking if people can hear me. Yeah, I've been cutting out apparently. Yeah, there's more I'd like to know on this, and in particular, I think the news about the walk-in at Boots, the City Health Centre. Given we've only just had that, I think there is a need for a further conversation about that, and whether that's members of this committee and potentially colleagues in the city centre wards that might, this will be news to them and have an impact on their residents. I've used that before. I know other people that have, and it's quite a key thing. So I think probably we need to arrange a further discussion specifically on the city walk-in centre. The other kind of slight concern I'd have is border issues. So I'm thinking about in North Manchester, where we already have an issue sometimes, given past events at North Manchester General, getting residents to use the A&E at North Manchester, when in fact if they have any transport, they can jump in a car and go to Oldham, or they can go to Salford Royal, and a lot of them do. And it's whether bringing this in for North Manchester General would just cause more of a knock-on effect elsewhere at neighbouring hospitals. It would be useful to have outside of this meeting some feedback on what discussions there have been there. If we take up Councillor Craig's suggestion, I think we would have to come back generally to this as a wider issue. But if we can put into the work plan a future report on general, not just A&E provision, but also 111, because it has been a while since we've had a formal discussion on that at this committee. And given experiences that we've related to and feedback we've had in general, it would be helpful to come back on that. So if we can agree with those provisos, otherwise that we note the report and ask that the committee's comments are taken on board. Is that agreed?
Agreed.
Brilliant.
Yep, agreed.
Thanks everyone.
Thank you.
Thanks to all the officers that have taken part.
You.
I thought that was a good discussion about something that's quite new, and we'll be getting asked questions by our residents. So hopefully, as the communication strategy evolves, that we're kept informed so that we can use our networks as well, and we can respond to our residents when they come with queries. That would be very helpful. But thanks again.
Thank you.
Okay, and now we move into what is in theory item 5. I think the COVID update. You've had the presentation through. It's also on your screens. Thanks to everyone that's waited with us to get to this point. But if you'd like to introduce, I assume it's you, David?
Yes, thanks, Chair. So again, with the problems with Zoom, can I just check that Andrew's put these slides set on the screen? Great. Thank you, Andrew. Thank you. So if we go to the next slide, please. So what I was going to do, I've provided the committee with an up-to-date version of the 12-point plan. And in the cover note, I've just indicated that for this presentation, I'm just going to focus on a few key things. First of all, I'll go through some of the key pieces of data and information, the most up-to-date information. I'm then going to go on to talk about targeted testing at scale, or community testing, as it's now called in the national guidance. And then also, as the Chair's just referenced, and Councillor Craig just referenced, I'll cover some of the issues around mass vaccination. I have got a slide as well that summarises the tier arrangements that obviously come into play a minute past midnight tomorrow morning. And then obviously happy to take questions on both the presentation and the 12-point plan. So in terms of the headline indicators, this is the data that I had when I developed the presentation. The most up-to-date data now includes Friday the 27th of November. This is validated data, so we can be sure that it's got all the positive results properly validated. And our headline rate has now gone down to 189.9, so we're below 200. So that's really good news. And similarly, our over 60s rate, and this is really important because this gives us an indication of likely future pressures on our hospital and care sector. And that's gone down from 243, as I say, when I wrote this, that's gone down now to 230. per 100,000. So both of those headline indicators are coming down and coming, down at a good rate. So that's reassuring. The positivity rate of our Pillar 2 test is also down to 10.4%. And we have regular updates, Councillor Craig, myself and the leader, with our colleagues at University Hospital Foundation Trust in Manchester, and Jane Edelston, the Medical Director, and Jill Heaton, the Deputy Chief Executive, provide us a weekly briefing on what the pressures are on the hospital system. We've got our briefing tomorrow. But when we checked the data earlier, it sort of confirms that, yes, things are stabilising in relation to COVID in our hospitals in Manchester. It's still very tight and there are still a lot of pressures on the system, but there is emerging evidence that there's a welcome reduction in the number and rate of new admissions. And I think it's just worth reminding ourselves in terms of where we were back on the 3rd of October. We had obviously the student outbreaks that we were dealing with, but the rate for the city was then 583.5. And we had the highest rate of any local authority area in the country at the time. I think we're ranked about in the mid-80s now in terms of local authority rates. So we have made real progress in bringing those rates down. And we're also now tracking the percentage reduction in our rate, our headline rate and over 60s rate on a weekly basis. And it's come down by approximately 33% in the last reporting period. Next slide, please. So as I say, I'm going to just focus on a few areas of the plan. The first is targeted testing at scale. So we have a number of existing programs that are using what I call the lateral flow tests. These are the tests that will give you a result in about 30 minutes. The specimens don't need to be sent to a laboratory like they do when you go to one of our other testing sites. So the testing sites that we have at Denmark Road, Central Retail Park, Abram Moss. There, when you take the test, your swabs and the specimens are sent to the Lighthouse Labs, Alderley Edge. But if you do the new lateral flow tests, you get a result within about 20 to 30 minutes. And MFT have commenced the asymptomatic testing of frontline staff. So staff are asked to test twice a week. So Greater Manchester Mental Health Trust, and I think it was referenced in their report earlier. As some councillors are aware, we've had a number of meetings recently. The universities now have their own programme as well to test students prior to their return to their family or parental home. So both universities, Manchester Met and the University of Manchester, commenced their testing programme yesterday. We had the figures reported last night, and there were no positive cases in the first day of testing for the University of Manchester. We're waiting for the Manchester Metropolitan University figures to come through, and I've got a follow-up call after this with university colleagues just to check how both Monday and Tuesday have gone in terms of those tests and what's happening. This testing programme will continue till the 9th of December to enable a safe return of students to the family home. We are obviously still in discussions with the Department of Health and Department for Education about the return of students in the new year, and we're finalising some of our plans with the universities. But probably most important now is that we will be invited, because we're under Tier 3, as members will be aware from tomorrow. We can put in a proposal for extra resources and army logistics support to develop our own programme of community testing based on the Liverpool pilot, but clearly we won't have 2,000 army personnel to support us. We've got to look at what we can do within the available resources, but Greater Manchester will be submitting proposals tomorrow. We're developing our own Manchester specific plans as well to commence a programme of activities over the next few months. Next slide, please. So probably of real importance to everyone. We know that the best route out of this pandemic is the availability of a safe and effective vaccine. And we know that 3 vaccines are at the final stage of approval. Pfizer seems to be the first vaccine in the pipeline. Have to be really clear, it's still not had formal approval from the Medicines and Regulations Health Authority. So, but we are expecting that shortly. And then the other vaccines, the AstraZeneca and the Moderna vaccine. Taken together, the government has purchased sufficient doses to vaccinate the whole population, but clearly we will need to look at which vaccine suits which cohort. We now have a project management office established. So I'm the senior responsible officer for the city for this programme, but I'm pleased to say Manisha Kumar, who you just heard from, is the clinical director lead for the programme as well, because most of the vaccine programme will be delivered through primary care and our primary care networks. You'll have heard in the evening news, we do have the Greater Manchester mass vaccination site at the Etihad. The first one in the region to be formally designated. So credit to our local team, actually, our local council team who worked with the authorities to make sure everything was in place. And that will not just provide a service for Manchester, but the whole of Greater Manchester. We're still waiting for some of the specification information and the directly enhanced service contract to come through. And our anticipation is once that arrives, we'll be notified of when the vaccine supplies will start to arrive. And we may be able to start a limited vaccination programme just before Christmas, but it will be limited. The real programme will be accelerated early in the new year. And we've obviously got to mobilise significant resource across our health and care system for delivering the programme. We've done some of our initial modelling based on the national cohort. So, as I say, plans have progressed really well in the last month. Next slide, please. And I'm aware of the time, so this is more just for information, really. This just helpfully summarises what the different tiers mean. And obviously from tomorrow, we're in tier 3. There is a formal review of the tier arrangements on the 16th of December, and it relates to some of those indicators that I presented on the first slide. So we will need to obviously look at those, and the government will review those. Tier 2 is set out as well, and then tier 1. But as I say, this is really just for information, because I obviously want to give members of the committee a chance to ask questions on mass vaccination and the testing programme. Final slide, please. So we've got now weekly task group meetings for both testing and mass vaccination, so that we can make sure those programmes are implemented. Mentioned the formal review of the tier arrangements, and as a committee we will be aware our 12-point plan is regularly updated and will be updating the next version at the end of this month to obviously make sure the committee get this on a regular basis at the start of 2021. Happy to take any questions now, Chair, about the report, plan and the presentation.
Thanks, David. Yeah, I've got a couple. Councillor Quay first.
Thanks, Chair. Thanks for the presentation. Obviously, we're all pleased to see things going in the right direction. But I've got a couple of questions. Number one, on critical care beds, what is the actual occupancy rate at the moment as a percentage of the total, both in terms of COVID cases and the overall occupancy? And the second question, there's obviously a lot of controversy around the restrictions, loosening them or not, and what impact that might have in the future. So could the Director of Public Health and Executive Member give us their views on if they believe that the proposed looser restrictions over Christmas, as they understand them at the moment, are sufficiently prudent in the current scenario based upon the difficulties we've had with being stuck in tier 3 and being stuck in some sort of lockdown for months on end.
Do you want me to respond, Chair, or take more questions first?
I'm actually, am I unmuted?
Yes, Chair.
Yeah. I'm getting confusing signals from this computer. Yeah, given the time, I think if we take a couple at a time, that might be better, even though that's not normal practice. Councillor Newman.
Thanks, Chair, and thanks, David. As usual, you're doing and you and your colleagues doing a brilliant job. Two questions, really. One is that although it's quite clear that over the last 3 weeks or so, as you say, the rate of positivity or positive tests has been going down consistently. It has been a slow measure, a slow reduction, and we're still at a relatively high rate. I like your view on how this compares to, how low we were in, July after the first wave, before the second one started. And particularly the issue of the over 60s age group. And clearly a positivity rate of 10% isn't a low positivity rate. I think our highest was around about 17, 18%. Some comments on that. And the other point, really, it might be a rhetorical question, but I like your answer. With the ending of the national lockdown tonight, albeit going into tier 3, and I'm not getting in this health scrutiny meeting the whole issue about economic support, which I understand and support the council's position on Andy Burnham's position on that. But clearly, we're getting a reduction of restrictions, and also over the Christmas period, as Councillor Clay has referred to. And my question really is, just because something is going to be legal to be done by people in Manchester and no longer illegal, doesn't mean that everyone has to do everything that we're now or going to be in the future allowed to do that increases the risk of infection, until we get widespread vaccination. Just because you're allowed to do it doesn't mean you have to do it all. So any comments on that? Thanks.
Could you take those two, David?
Yes, will do, Chair. So in terms of the critical care beds, I know that the number of critical care beds occupied by COVID patients at the Manchester hospitals, I think went down slightly from 50 the previous week to 46 this week. And sorry, Councillor Clay, I'll have to come back to you on, there is spare capacity, we know, there's always a contingency, it's been tight, but I'll have to come back to you with the split between COVID and non-COVID patients and the spare capacity. But I do know that the number of COVID patients occupying critical care beds had gone down slightly, but I will get that up-to-date information. It's on a separate dashboard, apologies, and I'll get that to you. In terms of the being in restrictions of some form or another since July, and it links to Councillor Newman's question as well around the Christmas period, that yes, Councillor makes a really good point. Just because something is allowed, the concern is, and it's a public health concern, that people take more risks, if I'm being honest. And we do know, and I've had anecdotes, but really good anecdotes, of people doing their own risk assessment for Christmas for them, their families. They're vulnerable, they may have family members who are vulnerable, and people taking a pragmatic, common sense approach. We don't have to have 3 households. People can do what they think's right for them. But yes, I do have concerns about that 5-day period, and the Chief Medical Officer has said the same, because we're just worried that would lead to a possible increase in cases early in the new year. And January is still a time when our hospital and care sector is under severe pressure for other reasons, cold weather, slips and falls, all of that. So yeah, we are trying to we're working with our comms teams, obviously, to get the messaging right for the Christmas period. My own view around the tea arrangements is that actually, and this is where hospitality has done a great job in COVID secure arrangements, that is something that many businesses in the city really have to be commended for, and we understand their frustrations at the moment. What we want is just a fair process for reviewing the data and looking at this in the round, but from a public health point of view, not losing sight of those core public health messages for our communities and our businesses. Councillor Newman's right. We are nowhere near the low levels we were at sort of July, August. It was early September when we moved across the 50 threshold, 50 cases per 100,000, and we saw many areas of the country go up very quickly. Many university towns and cities, as I say, we reached 580. But it is reassuring to see how we are coming down now, and that decline, we want to see it continue to come down, and we want the positivity rate and those over 60s rates as low as they can possibly be. So we just want to track that over the next few weeks and not lose all the effort basically we put in for months, and we need to get our messaging right. So I think happily bring obviously Councillor Craig in as well, who may want to comment on the question from Councillor Clay.
Yeah, thanks. And I'll keep it brief, but it touches, I think, on both what Councillor Clay and Councillor Newman's reference. I think there has been a lot of discussion around some of the rationale that sits behind the tiering. And I know there is a real perceived unfairness, particularly when we look at some of the historic north-south divides that we tend to have in this country. I think from my perspective, one of the key things that is really important for us to keep emphasising as a city around our COVID rates is particularly around our trajectory. And I think as members have commented, it is a slow decline down. It's not an overnight decline. And on the new figures, we'll see ourselves going beneath 200 for the first time since the 23rd of September. And that is something that the messaging to the Manchester people has to be, the hard work and the sacrifice of Manchester people is paying off, but we can't let our guard down, and we can't run the risk of being back where we are at the minute in January. And I think part of what you'll see in the coming days as we move into the tiered system is trying to be really clear with people that yes, 3 households can mix over the same, in the same period over Christmas. But that's 3 households in total. It's not 3 households every day. And that's something we've seen particularly around feedback on the bubbles. Some people were taking the bubbles very seriously, where they would mix with 1 other household if they could. And some were having a different bubble every night of the week. So there's a real sort of challenge in there, I think, around some of the messaging. And also one of the things that lost credibility, I think, with the public was over the course of the summer, when whilst there was scientific evidence that suggested that pubs and restaurants were quite safe, squaring that with the public view that you can't have your mum round for Christmas, but you could go to a pub, wouldn't necessarily cut it, I think, with the Manchester people. So we will be encouraging people to be sensible, recognising that, you wouldn't perhaps choose the path that the government have chosen, but that's what we have to work with. And I think mitigating risk as much as we can over the festive period has to be front and central.
I've got 2 more questions. Councillor Doswell first.
Thank you, Chair. I just wanted to talk about the students again. Surprise, surprise. But I just wanted to say that as Fallowfield councillors, we've been pressing the universities and the Student Strategy Partnership for months for detailed plans on the student exodus. So this all comes under point 10 of the 10-point plan. And I just wanted to say that, David, I think you've done a fantastic job. Yourself and your team have been great in managing the outbreaks. And we can see that with the rate that's declined rapidly across the city because of the effective outbreak control work that's happened in Fallowfield. And I think I can speak for my residents and myself on this, that, you know, we're really grateful for that swift and effective action. What does concern me is that we are being reactive rather than proactive. And I understand that detail for the plans in January for the return of students is pending government guidance, which we're expecting on Thursday. But I'd like to know what lessons have been learned from October in terms of preventative work and what tangible measures we can hope to put in place from Thursday. I know what a lot of people don't realise is that Fallowfield is actually a mixed community of students and longer term residents, and I can't emphasise how concerned I am about the lack of concrete plans which would possibly lead to another series of outbreaks in January. And I want to be able to look my longer term residents in the eye and just tell them that we've done everything we can to stop this from happening. I do appreciate that, though, that these aren't necessarily questions that public health can answer, so this is more of a political element to it, and I wondered if we could use the collaborative partnership model that we've got in place to put sustained pressure on the universities to come up with these concrete plans and to make sure that we can communicate them clearly to residents, just because I can't be in a situation again, we can't be in a situation again in Fallowfield where we've got another series of outbreaks. It's just not fair on students themselves and the longer term residents. So any information and help on that would be great, thank you.
And we'll take them in twos again. Councillor Hitchin.
Thank you, Chair. My question was actually very similar to Jay's, but I also had a supplementary question as well, so I'm not going to ask the student one. My other question is in relation to mass testing. Manchester was and is the second city of the United Kingdom, and as far as I'm concerned, it's a great, fabulous city, but it's come to its knees in relation to COVID, like many other great cities around the United Kingdom and across the world. It's fabulous news regarding the vaccination, but I'm just wondering how long it would take to actually vaccinate the population of Manchester and then obviously Greater Manchester. I know that there is a tiering system, and rightly so, but I'm just wondering for the whole populace, do you have a guideline or a ballpoint figure of when the whole population of Manchester and Greater Manchester will be inoculated? Thank you.
So I'll kick us off first in response to Councillor Doswell's question, and then David will come in after me. I absolutely understand where councillors are coming from, that has been experienced over the last number of months, particularly in student populated wards. You know, it's been really quite difficult. I suppose a reflection I have has to put this quite firmly back on the government's agenda. And I think, you know, it was back in the end of September, beginning of October, I was in a meeting with the university's minister and asked the question privately at that point as to what were the plans at Christmas. And I was able to reflect on what we'd learned throughout the beginning of term, and of course the staggering of student returns in October. At that point, there was no answer for Christmas, and it appeared like it hadn't even been considered. So I don't want to get into the discussion of perhaps some of the things that our higher education institutions in the city could have done better over the course of the last few months, because I think that's a plentiful discussion to happen elsewhere. But from a public health perspective, I wanted to stress that at times, you know, particularly we saw it around media attention around MMU, universities in the city were having to operate without any cover or any guidance from their government department, and were having to develop a relationship with us locally that at times exposed themselves to media attention that the government simply weren't prepared to plan for. And I do have concerns about January, and we've been making those concerns quite consistently to government. And I think this is why we've started to see some movement from government around where students should be tested prior to them returning to university. I think initially these conversations went along the lines that it was the Department for Education's view that they should be tested upon their return. And we made it absolutely clear that that wasn't acceptable, nor would it be acceptable in any university town, city or campus, and really stated the point that they should be tested at home prior to returning. So David can come in a bit more detail, but I just wanted to say in defence of the public health partnership that we've had behind the scenes in working with the universities, they have worked very closely with David's team around managing this, and we'll continue to press for that to be made mandatory. But it's been made clear by government that that's not their intention at the moment. So a lot of the focus is around pragmatic messages we could do in relation to higher education institutions. And just quickly on Councillor Hitchens' point that David will cover, I think it's absolutely an excellent point. Matt and Hancock put a lot of pressure on local areas to be ready for the 1st of December. Well, we're ready. We just need the vaccine. So on that, I'll hand over to David.
Thanks, Councillor Craig. Just on the, to Councillor Doswell, and thanks for your message of support, Councillor Doswell. It means a lot for myself and the team because we know, as Councillor Craig said, we did work closely with the universities. There were some real challenges, but we actually did help, I think, inform some of those national policy developments. I have to say, I've been frustrated by the lack of timeliness around some of the guidance, and that's led to GM recommending that we want Bolton, Salford and the 2 Manchester universities. The recommendation is students get tested in their home, family parental home before returning. I don't think that always sits well with national government, but that's our recommendation, and is supported by all the senior leaders at the universities. In terms of, we will though still retain the testing sites at the universities that have been used this week, both for use with students, but also for use for our community programmes. So that's, I think, been really helpful. That's where our collaborative work will help. I'm confident that both universities and the public health team, we want the same thing. We want clarity on assessing all the risks for January onwards, and none of us, as I made the point in meetings this week, we want to be focused on the delivery of the vaccine programme in January and February. We don't want that challenge again that we had in September, October, of having to deal with significant student outbreaks. And I think the universities want that as well. So I think we're all trying to make sure we get to the same place and also reassure our local communities that we've got a clear plan. And I would hope, I've arranged a meeting with the universities just before the break that we can then know from this week of testing, collect all the information, digest the government guidance when it comes out, I think, as Councillor Doswell says, on Thursday, and make sure we've got a plan. As I said, because we all want to have a better January than we did September or October. Yeah, excellent question, Councillor Hitchin. So I talked about the 3 vaccines being in the pipeline, and I talked about having sufficient doses for the population. I think, as Councillor Craig said, we're ready to go, and our ambition would be to do things as quickly and as safely as we can, and want to do that and get through all the priority cohorts as soon as we can. It's almost an impossible question to answer because I think as Councillor Craig said, we're ready to go and we still haven't got all the vaccine or all the guidance. But if we can really progress at speed, then I think short-term goal is that we definitely have vaccinated some of the priority cohorts, our most vulnerable residents, our care home staff and care home residents, our older age groups, our health and social care workforce. Obviously, we want to do as many of that group as possible by Easter. But then I think as we expand the programme, we'd aim to get through the rest of the adult population. This vaccine, we won't be vaccinating children or young people. It's just an adult vaccine. And, you know, we would hope then to motor on and do as much as we can by the summer. I know they sound vague headlines, but that is about being pragmatic and realistic about the vaccine supply and the logistics of delivering such a complex programme, which has never been done in this country before.
Thanks. Do members have any further points they want to make on this item? Splendid. I've just got one quick question, and it's about my ward borders two neighbouring local authorities, so it borders Bury and it borders Rochdale. You know, other bits of the city border other places, and what I've seen from what the directors of public health of each of the authorities is saying, it's about working together across Greater Manchester, and yet we have had some interventions from MPs of more than one party who feel that their constituencies are entirely different and should be treated differently, when we all know that you can cross the road and walk from Manchester into Bury. It's the same community and the same schools and the same hospitals and the same workplaces, or you can, without wanting to make a specific example, you can cross the road in Gorton and you're in Tameside. And yet, when you look at the figures, that they're not a million miles apart. I realise that the further out from Manchester into some of the more rural bits of Greater Manchester you go, it's a bit different. But how well is this being managed between neighbouring authorities when there are these kind of shared communities that cross borders? I realise that MPs can sometimes see their constituency as a magical bubble of its own that's uniquely special, but we all know that's not how our communities work. So what are we doing about that?
So, Councillor Farrell, all 10 local authorities will have to work to the same specifications for their primary care networks and actually work through the Joint Committee for Vaccination and Immunisation, the national priority list. So everyone would have to work methodically through those groups, and there is a Greater Manchester framework. So Jenny Osborne in my team attends a weekly meeting with Greater Manchester colleagues. So certainly workforce issues, our hospital trusts, as you know, serve bigger catchment areas. And as you know, many of our patients registered with GPs live outside the Manchester area, and some of our residents are registered with Bury, Rochdale, Tameside GPs. So it has to be done under a Greater Manchester framework. Where there might be some differences are, and this is a practical issue, is where some of the Pfizer vaccine, it's quite logistically difficult to deliver this vaccine because of you need freeze the vaccine at -80, you have to use it within 5 days. One practical concern is that we don't waste any vaccines, and sometimes we might take a pragmatic view around giving access, quick access to other priority groups just because we don't want to waste a vaccine. We have to get national sign-off for that approach, but that is a view that we would not want to waste vaccines and have a pragmatic view, but there should generally be a consistent approach across Greater Manchester. And the Etihad, as I've said, is a Greater Manchester mass vaccination facility.
Thanks, David. If nobody has any further points on this, can we thank you for your report. As ever, thank everyone in your team and our NHS partners as well for all the stuff that they're doing. Hopefully, there's a bit of respite over Christmas, but we are where we are on that, I think. So thanks again, and I'm sure we'll be having a similar report next time we meet in the new year, and hopefully with some better news and some real progress in dealing with this. Okay, that only leaves us with item 8, the overview report. Are we okay just to note that for now? And again, I think we've turned up some more stuff today that we want to come back to. But at the moment, we're just going to have to respond to circumstances as they change, I think, and keep it as open as possible, so that we can give it some decent consideration. But thanks everyone. That was an interesting meeting. That turned up some stuff, some new stuff during the meeting that we might not have known about. We're going to have to come back. We obviously we can't have our annual Health Scrutiny Christmas party, which I did fully intend to start as a new tradition this year. But what can you do? But I've got plenty of Jaffa cakes here to eat, which I might share with Basil and anyone else who's knocking around in the town hall. So thanks everyone, and if I don't see you before, have a good Christmas.
Thank you.
Thank you.
Cheers everyone.
Thank you. Bye everyone.